Good evening, and thank you for participating in this seminar talking about brain tumors in children. And I hope that you will, at the end of this talk, have a good sense of recognizing the diagnosis of new brain tumors, some information about the epidemiology and the outcomes, and then some of the exciting new treatments that have been developed in recent years. As you can see, I have no disclosures to report concerning this presentation. So I wanted to start just by putting brain tumors in context. As you know, although there are 1.5 million diagnoses of cancer in the United States each year, only about 15,000 of them are in children. But as you can see, as you look at this slide with the second line being brain tumors, you can see that in all age groups of children, brain tumors account for either the second most common or third most common when you think about infants, type of cancer that we see uh, in children. And so, in that context, I think it's really important be, uh, to be able to recognize some of the signs and symptoms because again, these patients by and large uh, will present to their primary care physicians, ERs, or other physician teams. So we just think about brain tumors in children. You can see that there are that these tumors can occur anywhere in the central nervous system, but the most common areas we see are those that are in the pituitary and supratentorial region, particularly craniopharyngiomas and germ cell tumors. Cerebellum is the second most common. Uh, and and then brainstem is less common, but if you put those together, you can see that the vast majority, about 2/3 of all brain tumors in children, end up being in the posterior fossa as opposed to supratentorial. And again, by histology, you can see that there are many different types of tumors, but pilocytic astrocytomas are the most common tumors we see in children. Again, as opposed to adults, where high-grade gliomas would be much more common, and then tumors of the pituitary, malignant gliomas, and embryonal tumors. And just you will note under embryonal tumors, medulloblastomas are by far the most common, but we also have this category of PNET. In some of the data I will show you further on, you will see that with the new technology we have for really specifically diagnosing uh, tumors and what are the uh, types of cells that they originate from, as well as the uh, driver mutations. We actually no longer use the word PNET because it is now uh, four different subtypes of what we just term embryonal tumors of childhood. If we talk about incidence range across the age spectrum, you can see that gliomas tend to be most common in infants, particularly those with neurofibromatosis. And so those go down a little bit as the children get older. But really, the others are pretty flat, with the exception of germ cell tumors in the pituitary, which dramatically increase in numbers during the teenage years. And here is just, this is from a 3-year time span here at our clinic at Nemours Children's Specialty Care and Wolfson Children's Hospital in Jacksonville. And what you can see is that going along with what you saw previously, The most common tumors that we tend to see are the astrocytomas, mostly low-grade astrocytomas, with other types of gliomas number two, and uh, DIPG sitting at, or brain stem tumors sitting at 10% or approximately, and then medulloblastomas being the next most common. So that's very similar to what we saw if we think about the overall epidemiologic data. In terms of presentation, CNS tumors can present, as you can see here, due to either signs of local invasion, compression of normal structures, or very commonly due to obstructive hydrocephalus and increased intracranial pressure. The other thing in general, it's not uncommon to have a very prolonged period of symptoms prior to diagnosis. And in one study, that was a median of 3.5 months, but can range anywhere from a very acute onset up to 6 months to a year of having symptoms before the tumor is actually diagnosed. The next thing that's very common in terms of brain tumors is the symptoms often start as very nonspecific symptoms with a very insidious onset. And that's really important because brain tumors are notorious in terms of mimicking other much more common illnesses, such as viral infections or uh, other types of infections, migraine headaches, visual problems. So, and just as an example, developmental regression is something that is seen fairly commonly, I think, in the primary care practice. And there are many more common reasons for that to happen. But as I'll show you, I think when that happens, one should consider brain tumors as well. So here are just some of the signs and symptoms of increased intracranial pressure in patients that are diagnosed with central nervous system tumors. And so in infants, probably the most common is an increased head circumference. And you all know how important it is to be watching head circumference in young children. Certainly when you have increased pressure, you can get splaying of the sutures or an elevated fontanelle. One of the things that we see not uncommonly as a presenting symptom is head tilt. And again, we talk about torticollis, which would probably be much more common, but when you see that, this is on the differential. Loss of developmental milestones is a very important sign and symptom, because really that is something that shouldn't happen with any of the more common diseases that are seen. Increased irritability, weight loss, and anorexia round that list of symptoms out. In older children, the biggest things are headaches, vomiting, particularly vomiting that occurs first thing in the morning. Many of our patients are diagnosed by ophthalmology because they come with blurry vision and are found to have papilledema. Children who have been doing well in school and have all of a sudden unexplained declines in their academic performance, increased somnolence, personality changes, and again, weight loss. So if we look at overall symptoms of brain tumors in children, you can see that the majority is these symptoms of increased pressure. So headaches, nausea and vomiting, and then next, and papilledema. And then next is, because the majority of tumors in children tend to be in the posterior fossa or infratentorial, problems with gait or coordination are very, very common. And less common would be seizures, which would, because you wouldn't see those in the posterior fossa tumors, but that is something that will occur much more often in the supratentorial tumors, um, in these children. Other things, again, change in behavior, school performance can be 7%. Cranial nerve palsies, particularly with brainstem tumors, and abnormal eye movements and level of consciousness are not very common presenting symptoms. In infants, as we discussed, macrocephaly by far the most common, vomiting, irritability, lethargy, and coordination problems. Weight loss is a much more common symptom in infants than it may be in the older children. And we talked about these head tilts and squints and changes in development as things that are not uncommon in infants presenting with brain tumors. And knowing what the symptoms are with a good neurologic exam is very important, because that again can help in terms of if this patient has a tumor, where in the brain or spinal cord is it? And so you can see here, posterior fossa tumors are very, very common to have gait abnormalities, cranial nerve abnormalities, and signs of increased intracranial pressure because of obstruction of the third and fourth ventricles. In the brain stem, the most classic symptoms are cranial nerve deficits, because that is where all the cranial nerves exit the brain. In spinal cord tumors, not uncommon to have either radicular pain or weakness, but also issues of bowel bladder control. And again, these symptoms can sometimes mimic many other things, and so need to be thought about. Optic pathway tumors will most commonly present with visual disturbances, and the hypothalamic tumors or the pituitary tumors, you will often see symptoms of endocrine disturbance or growth and growth failure. So as I said earlier, symptoms mimic many more common diagnoses, and so we have to keep that in mind. Brain tumors are relatively rare, so you're going to think of other things first, and that's okay. But when you're thinking of these other things, which are much more likely to be the diagnosis, please be aware of the following. Symptoms that don't go together well to account for something else like a viral illness. Symptoms that persist for a prolonged period of time, when you would expect that, for instance, with a virus, they would have resolved by now. Vomiting not associated with nausea, particularly if it's occurring in the early AM. Loss of milestones and change of behavior or school performance are things that are harder to explain with other etiologies. And then acute vision changes. There's really very few other things, other diagnoses that can cause acute visual changes. So the good news, this is just looking at prognosis of children diagnosed with brain tumors over 1975 to 2016. And you can see that overall, the survival rates have gone, 5-year survival rates have gone from 55%, so half in the 1980s, to now over 80% of all children with brain tumors are cured. Now, again, this is very dependent on the type of tumor, and the location, but in general, we're doing much better in curing these tumors due to better surgeries, better ways of doing radiation, and better use of chemotherapy and some of the new therapies that we'll talk about. Okay. Now, in this, you will see that that drops down when you look back 15 years in terms of survival. But again, um, those late relapses or causes of death are continuing to decrease. Unfortunately, not all brain tumors are the same. So though we're doing very, very well in the low-grade tumors, particularly the low-grade gliomas, which remember are the most common tumors we see, the same is not true for some of the more malignant types of tumors, with ependymomas, medulloblastomas, and pineal tumors having an intermediate prognosis. And then those that are occurring in the brain stem and the high-grade gliomas, we still have a long way to go in terms of our ability to cure those patients. Now, there are some genetic syndromes that are often associated with an increased incident brain tumors. Those would include neurofibromatosis type 1, where particularly optic gliomas at a young age is fairly common. Neurofibromatosis type 2, where acoustic neuromas or schwannomas, so changes in hearing are the symptom you may most commonly see, are more common. Tubular sclerosis, where you can get some benign tumors for which there are now new therapies. And again, these tumors are associated with a good prognosis. The basal cell nevus syndrome or Gorlin syndrome, and of course, Li-Fraumeni syndrome, which is a family cancer predisposition syndrome where you would get a history of multiple family members who have had cancers, particularly at younger ages than one would expect. And particularly that is an increased incidence of medulloblastomas and embryonal tumors, along with many other types of tumors in children that are not in the central nervous system. So if you're contemplating, could this be a brain tumor, knowing the family history can often be important because not only does it direct you to a diagnosis, but also in many of these genetic syndromes that are associated with an increased risk of other malignancies, we want to try and avoid things like radiation because we know that areas that have been irradiated are more likely to develop secondary tumors. And one of the things that many of you will see in your practices is the issue of late effects, particularly for children treated at young age. So neurocognitive deficits are fairly common. Fortunately, with newer treatments, newer ways of giving radiation, which really are better able to focus what parts of the brain see the radiation, those global IQ deficits are not as significant as they once were. But again, subtle neurocognitive deficits that do impact um, uh, school performance and function are very, very common. And the most important issue with these deficits is if you recognize them, there are many techniques for overcoming them so they do not have to result in decreased quality of life or school achievement. We do see children who have had brain tumors, symptoms of depression, and post-traumatic stress disorder from the effects of having a brain tumor and being isolated from peers and worries about the future can be quite prevalent. Many of these kids will not relate well to other peers of their own age, probably because of the amount of time that they have spent uh, with adults and being isolated from their peers, not going to school, etc. Endocrinopathies are a tremendous concern, particularly anybody who's had radiation or surgery to the hypothalamic or pituitary region. Um, uh, and probably growth hormone deficiency is something we see in quite a number of our um, long-term survivors. Um, we are also recognizing with increased frequency the issue of radiation-related vasculopathy that needs to be uh, found and then treated. And so, in our survivors of brain tumors who have had radiation, particularly around the circle of Willis, we will often get MRAs on a routine basis just to make sure we're not seeing any types of vasculopathy. Our neurosurgery colleagues have developed many new techniques uh, to treat these before it gets to the point of patients having uh, either silent or significant strokes. And then we talked about second malignancies. Second malignancies can occur from the side effects of radiation to the local areas, but also from chemotherapy that's been given systemically. So I think that's given you a flavor for the importance of just having this on your differential. And again, I would stress when somebody comes in with symptoms of um, vomiting or change in school performance, there are other diagnoses that would be much more likely and common, but it's those other issues not getting better, associated with other symptoms so where it doesn't make sense. And those are the time, or a prolonged period of time, those are the areas where you have to start thinking about tumors and perhaps getting some kind of radiologic evaluation. So in terms of treatment, we have diagnostic biopsies, which are becoming even more important as we learn more about differentiating different types of tumors. We have debulking procedures, which in some tumors can result in a big difference in outcomes. And then more and more are newer techniques in terms of the ability to resect the tumors. And I believe that Dr. Aldana will talk about that more in his presentation. We are fortunate in Jacksonville to have the largest pediatric proton center in the world here. And the advantage of proton therapy versus photon is really a matter of um, targeting the radiation so that we can spare both uninvolved parts of the brain, but also organs outside the central nervous system from any impact of radiation. And then radiosurgery, or the so-called gamma knife, which is often used in adults with very small tumors in very elegant regions of the brain in which surgery is not uh, likely to be beneficial without lots of significant side effects. Um, that is used very infrequently in children, but occasionally. And then in terms of chemotherapy, um, we have, again, many new therapies, but I think the first thing is um, to make it clear with our patients and our families, is the goal of this therapy curative, or is it in terms of quality of life and survival time? And so that's something that we always try and make sure to distinguish. I'm going to talk about some of the exciting new work being done in terms of targeted therapies for brain tumors, particularly. And then there are many people who are working on ways to try and develop localized treatments such that we can impact the tumor, we can overcome the blood-brain barrier, but localize those treatments to the tumor area as opposed to systemic side effects. So historically, when we were diagnosing brain tumors, we would look at the histology, the location of the tumor, imaging characteristics, and then immunohistochemical staining to look at diagnosing the type of tumor. And then in terms of prognosis and how to treat, often that was based on the histology of the tumor, the grade of the tumor, so low grade versus high grade. The extent of the resection is very, very important. And then what type of CNS cells are causing the development of that tumor. And so if we look back in 2007, the WHO classification of tumors in the central nervous system was completely histology based. So look at it under the microscope, see what the immunohistochemical expression looked like, and then make the diagnosis. But a lot of work has gone into better understanding of genomics in medicine, and that has nowhere has that been more important than in cancer. And so in 2016, the WHO classification was revised based on an integration of both phenotypic and genotypic parameters and looking at tumor genomics. This is really changed how we think about brain tumors, and it resulted in more precise diagnosis, being able to better risk stratify patients, pick treatments, and even results in differences in terms of prognostic outcomes. So the molecular profiling can be done in a number of ways that you can see here, looking at the actual genomics, the DNA genomics to look for mutations or alterations in DNA copy numbers. We can look at methylation of the DNA, look for gene fusions, and then the epigenetic or histones, which are involved in the regulation of gene products. And so now, when we're trying to decide what is the right treatment for a patient, not only are we looking at the tumor under the microscope, but we are getting this molecular input. We're looking at some of the radiologic features. So for instance, is there metastases? And we're putting all of that information together to come up with the best potential treatment for that particular patient. So I'm going to give you a couple of examples of how this has changed the way we do things. If you look at medulloblastomas under the 2007 WHO criteria, we had 4 subtypes of medulloblastoma, all based on histology. So there was classical, desmoplastic, and then anaplastic and large cell. Anaplastic and large cell thought to be higher risk, the others thought to be lower risk. And so we then divided our treatment to standard risk patients and high risk patients based on, did they have a complete resection? Do they have metastatic disease? Is it one of the more high risk histologies? And what is the age of the patient? Those are the things that would determine both prognosis as well as treatment. So in 2016, however, we learned a lot about genomic subgroups of medulloblastoma, and the details here are not important, but you can see that there were 4 subtypes identified based on the genomics of the tumor with very different genetic signatures. And if you look towards the bottom, the result was that you had 5-year survivals ranging from 94% in the cases of WNT positive medulloblastomas to 32% in the patients who had group 3. Again, this has been further refined, and so now we talk about 7 different subgroups of medulloblastoma. And again, each one has its own particular age range that we see it in. Each one is associated with a different incidence of metastatic disease. Very, very different prognoses, ranging from, again, almost 90% for the WNT to 22% for the high-risk group 3s. Very different cytogenetic signatures that you see below and different gene expression. And so what we can now do is try and determine which are the patients that need more aggressive therapies, which may need less aggressive therapies, and can we identify therapies that specifically target the driver mutation for that particular tumor. It's really vastly changed how we approach these patients. So again, can we develop targeted therapies for those genetic changes that we see commonly, like the WNT or the sonic hedgehog? Can we reduce therapy but still maintain the good prognosis in those very good risk patients? Can we escalate the therapies to improve outcome in the higher risk patients? And can we better define what types of therapies we need? So which are the patients that really truly need cranial spinal radiation to prevent future metastatic disease versus those who are more likely to come back locally, where maybe just focal RT would answer the question. I'm also going to show you now the example of the astrocytic tumors. So here are the different types of astrocytic tumors that were listed in the 2007 WHO criteria. And you can see there were about 8 subtypes of astrocytoma in children that were identified at that time. Again, here's 2016, and you can see that there are many more subtypes of astrocytomas that are associated with very different outcomes and perhaps benefits of certain treatments. And so this is very important now in seeing what we can, what is the best treatment for a particular type of patient. And again, this is manifest into multiple subgroups of, this is in this case, high-grade gliomas. And you can see those high-grade gliomas subtypes are affect different groups of patients, different parts of the brain, have different driver mutations. And if you look at the bottom, they range from the midline H3K27 tumors who have a very, very, very poor prognosis to the PXA-like tumors where it says greater than 4 years, but that's because we haven't reached the median survival. Those patients do extremely well and tend to be the younger children. So again, where this all really changes how you approach management for these patients. And this is just an example of the signal transduction. So what causes the tumor to start growing? So it is the normal signaling mechanism that somehow gets, let me say, stuck in the on position. And so what you can see in the blue are the different genetic mutations that we commonly see in children with brain tumors. And then in the green, what the targeted therapies that particularly block that, the effect of that mutation, such that these patients, rather than being treated with systemic chemotherapy and radiation, in some cases can be treated with just taking a pill once a day for a prolonged period of time. And so we are now using these drugs very commonly in our patients with brain tumors. The BRAF inhibitors of dabrafenib and vemurafenib, the MEK inhibitors, sulimetinib, the mTOR inhibitors, and the VEGF inhibitor of Avastin or bevacizumab. These are things that are now commonly used in our armamentarium to try and cure more of these patients, and more importantly, allow them to grow up as healthy adults. And so as this evolves, we are now trying to do this on a worldwide basis. And in the US, the National Cancer Institute has the MATCH trial, where we have this whole list of targeted therapies and what their target is. And then we are testing all of our patients for these genomic changes. And if they have the driver mutation that may be treated by one of these drugs, these trials are available to treat those particular patients. In Europe, it's called INFORM-2. And we anticipate that in the not distant future or the near future, perhaps 50% of all children with brain tumors, and this goes for other kinds of cancers as well, will have actionable mutations such that we can treat with these targeted therapies, which would be already is a revolution in the treatment of cancer. Now, there are barriers to doing this. One is the technology available? It is very expensive, and will insurance pay for it? We run into that problem a lot. These are very complex genetic analyses that are done. And so interpretation of the results is a new skill that many oncologists and geneticists and pharmacologists are now needing to learn so that we can best serve the needs of our patient. And then the cost and availability of the targeted treatments. So some of these new agents can be incredibly expensive, and they're being taken for very prolonged periods of time, which makes getting them to the patients sometimes very, very difficult. So that's the targeted therapies. Another really exciting new area of potential treatment for pediatric brain tumors, as well as other cancers, is the use of immunotherapy. And this works by harnessing the immune system to attack tumor cells. So we know that one of the factors involved in tumorigenesis, the development of tumors, is that the immune system, which typically recognizes abnormal cells and destroys them, in some people or with some tumors, the tumor develops an ability to hide from the immune system. So the immune system no longer recognizes it as a foreign or something that needs to be destroyed, and therefore allows it to grow. And we want to try and reverse that. And so how do we use those? How do we develop those types of therapies? How do we integrate them with the other therapies? We kind of use them to get synergy. And can we find specific antigens on the outside of tumor cells that we may be able to overcome? And again, can we now get some of these therapies better into the brain, where the blood-brain barrier has caused a lot of difficulty in treating children with brain tumors? So there are a variety of different types of immunotherapy available, and those are listed here, but really exciting things, the checkpoint inhibitors, which are now used in a wide variety of adult carcinomas and other types of tumors, but now perhaps being able to be used in some patients with brain tumors. CAR T cells to attack the brain tumors and get, and the big task there is making sure we can get them into the CNS. Oncolytic viruses, such as polio, utilizing poliovirus or herpes viruses, or reoviruses to really perhaps inject them into the tumor and get them to destroy tumor cells. Um, uh, Antibody drug conjugates are being tried in many different studies, and the use of tumor vaccines to try and enhance the immune impact on those tumors. Again, the important limitations here, this is a brand new field, and there is some very exciting uh, studies being done with that all over the country, but even here in Florida, at the University of Florida, at the University of Miami, and some of these studies at our center in Jacksonville, as well as other children's hospitals. So the important things are to identify the target. We probably have to decrease the amount of tumor as much as possible because we think that these types of therapies are most effective when they are just used to get rid of that small number of cells that are left after surgery or radiation or treatment. Um, Oftentimes, we need to get the tumor cells up front to be able to develop these immune therapies. And so we need to think about this right when the patient is first diagnosed. These therapies right now are of very limited availability, and the impacts of the blood-brain barrier and delivery systems is an area of intense investigation. But I think we're going to hear more and more about these types of treatments as we move forward. Now, I want to stress that, you know, having a child with cancer, and especially a child with a brain tumor, is a very daunting thing for a family, for the patient. Um, and it truly does take a village uh, to care for these patients. And it's very important that these children be treated in a center that can provide a comprehensive approach to their management. We know that that is how we end up with the best outcomes. And so you can see here all the people who are regularly part of our comprehensive neuro-oncology program and are interacting with those patients and their families to try and help. And even added to this list is there are so many things that our community has wrapped their arms around some of these patients to help them in order to navigate the complexities of treatment. I will summarize that. Remember, brain tumors are the second most common group of tumors in children. They can have a very insidious onset and mimic many other diagnoses. And so when you are approaching a patient that has chronic headaches, behavior changes and school changes that are not easily identified as with another cause, new onset endocrinopathies, or particularly persistent vomiting, this has to be on the list of things that one considers. So not everybody with a headache needs an MRI scan, but as we have discussed, when you meet those criteria, please make sure that you're thinking about this in your differential. Treatment is multimodality, and we have to have the whole team approach to best manage these patients. Outcomes vary based on tumor type and location, and we talked about that. And late effects are common, and part of our job is to try and mitigate those late effects, and that has become a bigger and bigger part of our development of new therapies. This is just an example of the part of our team that touches each of these children and families who have brain tumors. And so this is the village that is helping our patients.